So yes, my talk's all about how myself and colleagues at the Westminster Homeless Health Counselling Service found that the amount and the extent of the challenges we were presented with almost forced us to develop a new way of working psychotherapeutically, which we've called pretreatment therapy. Pretreatment therapy is very much based on pretreatment, which Jay Levy developed as an outreach model in the States. And his latest book has just come out on the 1st of March with several contributors. The book's going to be available this afternoon after the talk. So the reason we developed pretreatment therapy is that the challenges we faced called for an enhanced response. And because of an enhanced response, we felt that the measurement of any change or any progress could not be that usually used with mainstream treatments, that a meaningful index of change had to take into account the different starting points homeless people begin from. So today, I will describe the challenges, which I'm sure everybody in this room already knows, so I might skip over that quite quickly. I'll very quickly describe the 5 pretreatment stages, pretreatment therapy stages, and then I'll quickly go over some of the markers of change, which might be quite a meaningful way to see whether our approach is helpful to people or not. Okay. So the challenges, the first one, of course, is trimorbidity. That trimorbidity, as we all know, is a mixture of physical, mental, and addictions-based ill health, with roots, as we've heard already today, in complex trauma, including child neglect and abuse. The extra challenges which homelessness itself brings to that are a limited time horizon, surviving through the day. As we've already heard, competing multiple priorities and appointments. People only have a certain amount of time, and not always when they need it. They're rushing around. A lot of people, unfortunately, because of adverse childhood experiences, suffer from the horrible label personality disorder, which I prefer to call and think about as a traumatized personality. Because of the chaos of homelessness, because of a lack of a safe, secure space, the trauma reaction keeps getting triggered off. People are exposed to triggering events, maybe an assault, maybe the theft of their only belongings. All sorts of things will trigger a person's trauma reaction, which again, because of the lack of a safe, private shelter, has no opportunity to calm down. So once the trigger reaction is triggered off, it will last much longer than anybody else's trigger reaction. Hence the need to turn to self-medication, maybe alcohol, maybe drugs, to tamper down that trauma reaction. Then, of course, a lot of people have had a long history of toxic help. I'll be defining these things along. Chronic shame and a negative identity. Also, people, because of adverse childhood experiences, have developed an insecure attachment style, whereby people aren't trusted. I'll go into it much more. But the outcome of that is there's very little epistemic trust. Epistemic trust is the faith in the validity and relevance of knowledge transmitted by a professional, including a healthcare professional. Hence, non-compliance with treatments, non-compliance with medication, because for people in a homeless situation, it might be perceived and it might be experienced as not relevant and not valid. But that has its roots in early childhood adverse experiences. I've mentioned personality disorder. Basically, it's enduring maladaptive patterns of coping, thinking, managing emotions, and relating to others. So as you can see, it's very much all-pervasive. It's a major unfortunately, it doesn't come on its own. It comes with a whole variety of other symptoms, other signals of distress, which usually distract from the underlying traumatized personality. So people will present maybe to a specialist GP surgery for the homeless, maybe with depression, or maybe with an eating disorder. And that's what will be treated without recognizing and therefore not addressing the underlying traumatized personality. It's incredibly difficult for someone who lacks a safe, private, reliable space to engage with a regular treatment program. It's incredibly challenging. So people, and on top of that, if people have a traumatized personality, they do find it very hard to comply. Also to have the mental and emotional space and physical space to access their own thoughts and access their own feelings and be able to articulate them. It might be too dangerous on the street to be aware of just how terribly hopeless you're feeling. So best kept out of mind. Also, it's very difficult to engage in a relationship. The problems, as we saw, are very much about the person. What a horrible thing to have told about oneself. Oh, your problem is you. Awful. What hope does that give? What motivation does that give? Especially when everyday life is so difficult anyway. And also, because of relentless suffering, people need and crave understanding, empathy for the suffering, rather than the means of alleviating it. And that's a very human, basic need, which we all need sometimes. And we all turn to loved and trusted ones when we feel low. Who do isolated, desperate, homeless people turn to in those situations? So those are some of the challenges. And to put the homeless issue in perspective with mainstream mental health issues, specialist personality disorder treatment centres offer 2 years treatment, up to twice a week, plus a series of activities and skills groups. And they demand that people are addiction-free and have a stable address. So that's the housed population, and that's the special treatment available for people who have a traumatized personality but are housed. So what then of homeless people who are also suffering from a traumatized personality? They cannot access those treatment centres because they don't have a fixed address and they need to self-medicate. So they're barred straight away from specialist care available. Toxic help, a history of toxic help, a history of abuse, maybe in the care home, maybe in the family, maybe at school, whatever. Also, as I've already talked about, limited, ineffective treatment. For example, the underlying traumatized personality is not picked upon. but the superficial symptoms are. Therapeutic dissonance, whereby if someone is lucky enough to have access to a therapist or a counsellor, the counsellor's view of that person's problems or that person's coping strategy differs markedly from the person seeking help. That creates confusion, that creates a dissonance, and that can be extremely painful. And the usual outcome to that kind of situation is that the person drops out of treatment, unfortunately though, blaming themselves, not the therapist or the counsellor. And this adds to the history of compound sense of failure and being untreatable. Social dissonance, whereby people who survived on the streets have had to adapt to street life, to surviving on the street, to the norms of street culture. When somebody comes into a medical establishment, there are different norms of social interaction. The capacity to move in and out of social roles, the patient role, the expert role, etc., etc. Someone maybe who spent several years, even just several months on the street, might have forgotten those social conventions or might never have known about them. So again, there's an issue there of engagement. How does one engage when one's had to survive in such a radically different environment with such different social norms? Chronic shame. The shame of an abused child is much more than shame. It's a sense of self-disgust, even self-hatred. And unfortunately, therapy can reactivate that because of the power differential. Somebody lays their soul bare, but the therapist doesn't. Somebody takes the risk of exposing all of their suffering, all of their vulnerability, but the professional doesn't. There's a power imbalance, which then, of course, brings that person back to the power imbalance of being the victim at the hands of a powerful pseudo-carer back in childhood. So it's all of these very subtle psychological processes which healthcare workers, not just therapists, but doctors, nurses, social workers, housing workers, frontline workers, need to be aware of, that they can either heal somebody through the nature of a relationship they develop with that person, or they can make that person worse. It's very important. Negative identity, that's to do with social stigma. Goffman already went into that in 1968. Attachment theory, this is a big thing. Early experiences of care are internalized by infants, by babies, by children, and they lead us as adults. They affect the way we engage with relationships as adults. Our birth is our destiny, in a way. 4 attachment styles: the secure, the avoidant, the ambivalent, and the disorganized. The ambivalent and the disorganized styles are especially related to borderline personality disorder, which is a particular form of traumatized personality. For the ambivalent attachment style, the caregivers were unpredictable. Sometimes they were caring and available, sometimes they were not. The key thing is they were unpredictable. So the infant and the child learnt to maximize its articulation of need, to ensure they would get attention. But as an adult, when they seek help, they will be full on. For many workers, they will be too full on. That the need is too intense, and they then become labeled as manipulative, attention-seeking, etc. The disorganized attachment style, here the caregivers were also abusers, or at the very least they were frightening to the child. So because of the child's vulnerability, they need to have a caregiver. But if that caregiver is frightening, the child is in a catch-22 situation, where the only person he can turn to is a frightening person. So the child is then put in a terrible conflict, a terrible situation, which explains why, when they do turn for help as an adult, they will not trust the help that adult provides, even if they are socially designated to be a carer, like a health worker, for example. Because their experience of carers in the past has been one of abuse, neglect, or at least feeling frightened. And again, that interferes with the ability to engage with what's on offer. And the awareness of that helps us. 5 minutes left. Right, okay. So those were the, the challenges. There's a couple more attachment styles. These are the pre-treatment therapy stages. There's 5 of them. Pre-engagement, engagement, contracting, action, maintenance. Pre-engagement is really fundamental in earning the trust of somebody. Also demonstrating your care for that person rather than case managing them. That's a really big one. Understand the patient language, which Jay Levy really stresses a lot, and understand that person's life script. Engagement, you re-script the patient's life, you reframe the history of toxic help, you contextualize the self-blame, you inspire hope. Contracting, by then, hopefully, epistemic trust has been developed and put in place. Action, access mainstream treatments, initiate life changes, establish support networks. Maintenance, the support networks are maintained. We have an open door policy. When we discharge people, they can always come back to us. Always. Markers of change, there's a lot around. Changes in symptomology, welfare, quality of life measures, social activity, socioeconomic engagement. As I've already said, a lot of challenges. People start from way, way below where most other people are. Each of the attachment styles I mentioned has particular markers of ability to manage relationships and ability to express oneself. And what we're suggesting is that as somebody moves from the disorganized attachment style to a secure attachment style, some of these markers, for example, proximity, distance, trust, expectations of others, attitude to seeking, getting help, the attitude towards those markers can visibly be seen to change and can be recorded as changing. So the trajectory of engagement in a relationship can actually be demonstrated. And I'll just, so we've seen proximity, trust, there's a few more. The expression and management of emotions. So, for example, with the ambivalent style, it's frequent, dramatic focus on emotions, whereas obviously with a more mainstream one, it's balanced expression of emotions. I'll let you read and make your own kind of comparisons. A low, incoherent self-image, nuanced, solid self-image. Dependence, how comfortable are people with feeling dependent? For example, the disorganized, there's a strong conflict between wanting to be independent but feeling absolutely lost without it. Conflict management, constructive strategies versus inappropriate behavior, etc. Empathy. So those are relationship changes that can be observed. Narrative markers, the ability to express and articulate. Again, here we can see a marked difference between different relationship styles of engagement and different abilities to articulate. So coherence and credibility of the narrative. People who have not suffered trauma, they're coherent. They can move between different levels of narrative. Their narrative appears credible. It's easy to make sense of. It's easy to respond to. It's easy to diagnose. It's easy to develop a plan of action. Someone who's had a series of early trauma, their narrative's going to be unintegrated. I'm talking about disorganized style here. And their narrative is going to keep getting punctured, interrupted by trauma-related material. Memories that keep interfering with their narrative. So that's going to create a very strange impression in the clinical room. People might be labelled as mad or whatever. So just to give you an idea of the progress that can be charted against these different engagement styles. So coherence, balance in the descriptions, dramatisation or the downplaying of emotions. Again, very different ways of managing all of those aspects of articulating oneself. Description of emotions, abstraction versus specificity. So again, in the disorganized, we see that abstraction and episodic fragments are present, but they're poorly integrated. There's no theme, there's no general theme. Very importantly, the consideration of one's impact on the listener. Do we have an appreciation of our impact on the person who's talking with us? Some people have, some people don't. And again, that can be traced. A developmental change can be traced as the therapy is beginning to take hold. Verbosity, narrative orderliness, mentalization. So what I've been suggesting is that homeless people have very different life journeys to most other people. This calls for an enhanced response with much greater understanding of the impact of microscopic things in a relationship. It's dependent on our knowledge that we can make somebody worse with words, with our body language, or we can make somebody better. And because of that, I suggest that the way of measuring the impact of such an intervention has got to be at the microscopic level. It's got to be at the level of these very subtle changes in the ability to relate, the ability to deal with emotions, but also in the ability to articulate these things. Thank you.